issues related to recurrence of primary liver diseases post liver transplant in adults, and my focus would be autoimmune liver diseases because we have discussed much about hepatitis B, C and ALD here in this forum. This will be the outline. First we'll discuss what is the incidence of recurrent autoimmune liver diseases post liver transplant, then specific issues related to each of these, how to diagnose recurrent autoimmune liver diseases post liver transplant, and what is the effect of recurrence on long-term graft survival, and what is the treatment, and then propose an algorithm for that. If we looked at the incidence of recurrent autoimmune hepatitis after liver transplant, we can see that it varies widely from 33% at 3.7 years to more recent studies showing that up to 10 years 11 to 32% recurrence is there. But the most recent study in 2020, and interestingly in this study prednisolone was stopped at 3 months after liver transplant, and only 7.8% recurrence was there up to 60.7 months. Only 3 patients recurred. Now if we look at the risk factors of recurrent AIH after liver transplant, various risk factors have been identified, including HLA-DR3 positive recipients, HLA-DR4 positive recipients, moderate to severe inflammation on liver biopsy with hazard ratio 6.9, high IgG levels before liver transplant. It has also been shown to be a risk factor for recurrent AIH. And AIH without overlapping cholangitis has higher risk. That means if there is associated cholangitis, the risk is less. Dual immunosuppression has also been shown to be a risk factor in some of the studies. We'll discuss some of the risk factors in detail later. If we looked at the incidence of recurrent PBC after liver transplant, again very variable, varying from 9.6 to 22% at 5 years, and at 15 years up to 50%, and at 25 years up to 52%. And this is the most recent data of 2020, which showed that at 25 years 52% will have recurrence of PBC. And some of the risk factors which have been shown in various studies. First is the TAC based immunosuppression versus cyclosporine. This has been a risk factor. Younger age at liver transplant, especially less than 48 years. IgM levels more than 550 mg per deciliter. Gender mismatch has also been shown to be a risk factor. And HLA B60 and DR8 also a risk factor. Biochemical cholestasis that persists within the first 6 months has also been shown to be associated with recurrent PBC. If we looked at the incidence of recurrent PSC after liver transplant, most recent data shows that it varies from about 40 to 45% at 5 and 10 years. So quite high recurrence in all the autoimmune liver diseases. If we look at the risk factors, then presence of HLA-DR B108, acute cellular rejection and steroid resistant ACR, if occurs, they are risk factors for recurrent PSC. CMV mismatch is also shown to be a risk factor. Younger age, presence of ulcerative colitis, and including active IBD after liver transplant, or even occurrence of de novo colitis after liver transplant is a risk factor for recurrence of PSC. Older donor age, higher INR at the time of liver transplant. If patient develops biliary complications, then also it is a risk factor. Pre-transplant cholangiocarcinoma is a risk factor. So these are the risk factors. We'll discuss some of them. Now, is there any influence of DDLT versus LDLT, especially in recurrent PSC? And this data from USA and Canada centers have shown that there is no effect of the type of transplant, whether DDLT or LDLT, on either PSC recurrence or graft survival. And similar is the data for PBC and autoimmune hepatitis. So what are the specific issues that are related to factors affecting recurrent autoimmune liver diseases post liver transplant? So first issue is whether steroids should be withdrawal or long-term steroids should be given, and if withdrawal, at what time we should consider withdrawal. So this was the first study in 1999 from Queen Elizabeth Hospital. And before 1999, the immunosuppression consisted of prednisolone, cyclosporine and azathioprine. And prednisolone was weaned at 3 months prior to 1999, and they found that 27% was the recurrence and 3 patients needed regrafting. So after that the protocol was modified and to maintain prednisolone at 5 to 10 mg indefinitely together with the additional immunosuppressants. And the same group is published their experience in 2015 in 76 AIH patients, and this was post 1999, and immunosuppression was gradually tapered over the first 3 months to a long-term daily maintenance of 5 to 10 mg daily, and they showed that the recurrent IH was less as compared to what they have previously reported, and at 10 years it was 11%. However, there have been further studies and reports which have shown that steroid withdrawal should always be tried, and this was a study from USA in 66 AIH liver transplant patients, and before 1990 their protocol was prednisolone withdrawal to be commenced at 6 months at a dose of 10 mg per day and gradually reduced. After 1990 the protocol was prednisolone reduction starting at 1 month when at a dose of 20 mg per day, and then gradually reducing to 1 to 5 milligram daily if transaminases remains normal. And they found that 50% could be taken off steroids, and the recurrent AIH at 5 years was 24% in patients off steroid and 45% who were still on steroids. That means that patients who were on steroids were actually resistant, so they had a higher recurrence rate. And factors associated negatively with corticosteroid withdrawal were increasing dose of immunosuppressant and presence of IBD. This was more recent data in which 29% could be taken off steroids, and the recurrence rate on patients who were taken off steroids versus still on steroids was similar, and the patients who were able to be weaned successfully from steroids were older as compared to patients who could not be weaned off. Then there have been meta-analysis also, and this meta-analysis was published in 2020, and they found that whether you continue steroids or gradually taper steroids, the recurrence was the same. So it is better to try to withdraw steroids. So this was the ASLD 2019 position, which said that there is limited data to support long-term administration of glucocorticoids to prevent post-transplant rejection, graft loss, recurrent AIH, and reduced patient and graft survival. So a gradual withdrawal of glucosteroids should be considered after liver transplant. Now, one study has been published after that meta-analysis also, and which showed that this was the immunosuppressive regimen. Oral prednisolone dose was followed by a tapering regime and terminated at 3 months after liver transplant. The steroids terminated, subject to the condition that LFTs remained normal. So recurrent AIH in only 3 patients, and 5-year graft survival was excellent. Now second question is, which immunosuppressive regimen is good for AIH, which is dual or triple? It still remains inconclusive. There have been 2 studies. First showed that dual immunosuppression without aza or mycophenolate had higher risk of recurrence, but cyclosporine and TAC were equal in this setting. But another study showed that proportion of patients on triple versus dual therapy were similar in patients with and without recurrent AIH. So this remains inconclusive whether dual or triple is better. Now next issue is for PBC, whether UDCA should be given or not. It has been settled now. This was the largest study from the global PSC study group, and this was although a retrospective study, but in these 24% received preventive UDCA at dose of 10 to 15 mg per kg per day, and this graph shows that recurrent PBC as well as the graft loss was much less when UDCA was given as compared to when UDCA was not given. There have been few meta-analysis also. This meta-analysis published in 2020 showed that preventive UDCA was of no use, but Again, next meta-analysis in 2021 which showed that recurrent PVC in UDCA is 16% at 5 years in UDCA group versus 23.1% in no UDCA group, and if on including studies that have more than 9 years of follow-up, then also the recurrence is much less in UDCA group. Again, the third meta-analysis also showed that preventive UDCA is protective with a head-heart ratio of 0.4. So UDCA's preventive administration at a dose of 10 to 15 mg per kg per day should be initiated as soon as possible after liver transplant to prevent PVC recurrence and improve graft and patient survival. Next question is which immunosuppressive regime in PBC? This was a study from Global PSC study group, and this showed that PBC recurrence was much higher in the tacrolimus group as compared to the cyclosporine group, and the features that were associated with PBC recurrence on multivariate analysis were age at liver transplant, tacrolimus versus cyclosporine, and cholestasis, whether mild or severe at 12 months. So these three factors were associated, but TAC was associated with higher risk of recurrence. Again, there have been meta-analysis on this topic. The first meta-analysis of 2020 showed that there was no influence whether TAC or cyclosporine was used. However, next meta-analysis in 2021, which included 6 articles, showed that use of tacrolimus was associated with a higher risk, 2.62 for recurrence, and use of cyclosporine was lower risk. So cyclosporine A reduces PVC recurrence and should be considered over TAC as primary immunosuppressant after liver transplant for PBC. So next question is which immunosuppressive regime is for the recurrent PSC in liver transplant? Again, it remains controversial, and there have been 3 studies which the first showed that there was a trend for more recurrent PSC in the cyclosporine group, but it did not reach a statistical significance. Second showed that there was no significant use of influence of either TAC or cyclosporine, whereas the third one showed that tacrolimus increased the risk of recurrent PSC. Again, meta-analysis in this is also not conclusive. 2020 meta-analysis showed that TAC or cyclosporine is not a risk factor for recurrent PSC after liver transplant. But another issue that could be important in deciding the type of immunosuppression is the risk of IBD deterioration post liver transplant for PSC patients. This was the data from the Nordic liver transplant group, which showed that post liver transplant about 40% had deteriorated IBD activity. And if you look at the risk factors for deteriorated IBD activity after transplant in PSC patients, then besides age, tacrolimus, TAC plus MMF. So TAC along with MMF is a very high risk, 3.9 times, whereas cyclosporine as a azathioprine are protective for risk factor for IBD deterioration. And MMF obviously should not be used in LTDP recipients who have IBD, because MMF enterocolitis can occur, which can lead to, which can mimic IBD flare. So also IBD-free survival after liver transplant in PSC patients is more in TAC-free regimens versus the aza-containing regimens. This study also showed that percentage of patients who were active IBD-free was much less, were much higher when there was no tacrolimus in the regime, whereas if there was azathioprine, IBD free was much more as compared to without azathioprine. Also, aza-containing regimens protect against de novo development of IBD. In about 10 to 15% of the patients who do not have IBD pre-transplant for PSC, they develop de novo IBD after liver transplant. And again, the same study we showed that survival without de novo IBD was significantly higher in patients not receiving tacrolimus, receiving azathioprine, and the best was cyclo plus prednisolone plus azathioprine regimen. So cyclosporine A and aza-containing regimes are preferred in PSC liver transplant. Now, colectomy before liver transplant reduces risk of recurrent PSC. Many studies and meta-analysis have shown that colectomy before liver transplant, cholangiocarcinoma before liver transplant, these are the risk factors for recurrent PSC. But if colectomy is done before liver transplant, it is a protective factor. So, what can we conclude? That better control of inflammatory activity protects against recurrent PSC. There should be a lower threshold for colectomy in PSC IBD patients who need liver transplant. In pre-liver transplant setting, there is a role for routine annual colonoscopies for CRC screening. Now, incidence of colorectal cancer is much higher in post-liver transplant. It is 4 times in PSC-LT versus non-PSC-LT, and it is 10 times if PSC is associated with IBD subset. So, post-liver transplant, annual colonoscopy for PSC IBD, but if there is no IBD along with PSC, then every 5 years colonoscopy should be advocated. Now, how do we diagnose recurrent autoimmune liver diseases? These are the diagnostic criteria for recurrent autoimmune hepatitis: liver transplant for AIH, elevated transaminases, interface hepatitis, elevated IgG, autoantibodies, steroid dependency, and exclusion of the other causes of graft dysfunction. This is an important point. And the features that are classically seen in rejection, that is endothelitis and bile duct damage, are usually absent in recurrent AIH. This is the criteria for the recurrent PBC, liver transplant for PBC. These are the 4 characteristic histological features: lymphoplasmacytic infiltrate, lymphoid aggregates, epithelioid granulomas, and evidence of bile duct injury, persistent of AMA, elevated IgM levels, and exclusion of other causes. So definitive diagnosis is made when all the clinical and lab criteria are fulfilled, plus at least 3 of the 4 histological features are there. Probable diagnosis is when all the clinical and lab criteria are fulfilled, but only 2 histological features are there. But liver histology still remains the best way of diagnosing recurrent PBC, and it is more challenging than diagnosis of PBC in the native liver, because after liver transplant sometimes high levels of AMAs and IgM may persist, and the most characteristic finding is granulomatous bile duct injury. It is an infrequent, in 10 to 15% only, but it is a very specific finding, and this is the granulomatous bile duct injury. But if the granulomatous bile duct injury is not seen, then the cholangitis can be confused with acute cellular rejection. Then we have to see features of additional findings of periportal copper associated proteins, which will favor recurrent PBC, and if endothelitis is there, it will favor acute cellular rejection. These are the criteria for recurrent PSC. Again, it is a diagnosis of exclusion, confirmed diagnosis of PSC before liver transplant, and these are the cholangiographic findings or histology. And obviously exclusion of the other features are very important, like HAD, ductopenic rejection, and strictures, etc. Now, sometimes it is very difficult to differentiate between biliary strictures, non-anastomotic, whether it is due to PSC recurrence or it is due to the non-anastomotic strictures. This was a very old study, but very informative, in which cholangiography was done by percutaneous transhepatic cholangiography, and 32 patients received liver transplant for PSC, whereas 32 received for non-PSC disease, and it was shown that there was no significant differences in either the location, number, length, whether it was a diffuse or focal strictures between the PSC and the control groups. However, there were 2 findings that could favor recurrent PSC, and these were mural irregularity, as we can see, and mainly in the extrahepatic ducts, and diverticulum like outpouching. So these 2 features were more common in the recurrent PSC group. However, these were overlapping findings, and in most cases it is very difficult to differentiate between recurrent PSC and other conditions based only on cholangiography. So biopsy still may be required. So histology in the appropriate clinical context will support a diagnosis of recurrent PSC. Characteristic fibro-obliterative bile duct lesions or periductal concentric fibrosis, very rare, but if present is very characteristic. portal tract enlarged by bile ductular reaction, and biliary type of interface activity. And these are the other supporting findings: periportal copper associated protein deposition. So what is the effect of recurrent autoimmune liver diseases on post liver transplant graft survival? So if PSC is recurring after liver transplant, then there is a very high graft failure. These data from 2 studies which showed that graft survival is less if there is recurrence of PBC. Similar is the data, more recent data, which showed that graft survival with and without PBC recurrence, with recurrence is very less. But impact of recurrent PBC on graft loss remains modest. This is the largest data which showed that although the graft survival is less, but this is more modest as compared to recurrent PSC group, and similar is the data with the autoimmune hepatitis also. So how do we treat recurrent AILDs post liver transplant? This is the table showing the treatment. Recurrent AIH, prednisolone plus azathioprine with gradual withdrawal over 4 to 8 weeks, and maintenance prednisolone and aza should be maintained, and calcineurin inhibitor should be continued. 5-year patient survival after this regime is excellent. For recurrent PBC, only UDCA is available. Normalization of alphos will occur in about 50%, but the impact on graft and patient survival remains uncertain. Similarly, recurrent PSC, again UDCA is available, but again it can improve liver biochemistries, but impact on graft and patient survival still remain uncertain. So I will end with this algorithm. So post liver transplant management of AILDs, autoimmune hepatitis, these are the immunosuppressive regimes. Steroid plus TAC, whether dual or triple, we don't know. Withdraw steroids gradually, even at 3 months it can be done with cautious monitoring of liver function tests. If recurs, then treatment is with steroids with taper and AZA. Steroids plus AZA maintenance is must, and TAC should be continued. For PBC, as far as immunosuppressive regimens are concerned, cyclosporine is preferred over TAC. UDCA should be started to prevent recurrent PBC, and if recurs, then UDCA 10 to 15 mg per kg per day continue. For PSC, immunosuppressive regimes, avoid TAC and MMF because they lead to increase in the IBD activity and even more development of de novo IBD. Cyclosporine A and AZA regimes are preferred. Good control of IBD activity is important. For IBD PSC, annual colonoscopy, non-IBD PSC 5-yearly colonoscopy, and treatment if recurs, then UDCA 10 to 15 mg per kg, and management of other complications as needed. Thank you very much.